My name is Brian Feingold. I'm a pediatric cardiologist at the Children's Hospital of Pittsburgh. So I'm going to talk about advanced therapies for heart failure. I wanted to thank you for the invitation to speak. I'm really very pleased. This is my first time at the conference, and it won't be my last. So as I put this talk together and was sitting down and thinking about it, really, this is maybe a more appropriate title because there are no directed therapies at this point, as you all well know, for Barth Syndrome. There's really therapies for heart failure, and the therapies that we have are borrowed from adult therapies, as we just heard from Dr. Byrne. This could even say advanced therapy for heart failure because as I sat down and further thought about what I might say, essentially heart transplantation is the definitive therapy, if you will, and I will talk a good bit about transplantation and its pluses and minuses. It certainly has both. And these other things here I'll briefly touch on: mechanical circulatory support and just what I termed intensive medical support, because they're really not long-term therapies. These are things to help you out when you're in a pinch and the heart is really not working very well, but they're generally bridges, as we call them, to get to transplantation if you need it. So let's briefly talk about mechanical circulatory support. So this is what people will term VAD or ECMO, and so VAD is ventricular assist device, and ECMO is extracorporeal membrane oxygenation. And so these are basically machines which do the work of the heart when the heart is incapable of doing its work, which is pumping the blood. In the case of ECMO, ECMO also has an oxygenator in line, and so it can do gas exchange, and so it can both pump the blood and then route that blood through an oxygenator here that, termed a membrane lung, if you will, that does the gas exchange, puts oxygen into the blood, takes the carbon dioxide out. So this is a cartoon or a schematic showing how ECMO would be employed in a small child, and typically the jugular vein and the carotid artery on the right side of the neck are cannulated. These are rigid metal tubes that are placed through those vessels and into the right atrium and into the ascending aorta, the first part of the blood vessel that goes from the left heart to the body. And so the route of the blood would be drawing the machine. The pump is here. It draws the blood out from the heart, from the venous blood. This is the blood returning from the body with low oxygen. Draws it out through the pump, passes it through the oxygenator, if you will, and then heats it a bit because with all this tubing it can lose temperature and goes into the aorta. And so in this case you're providing flow, perfusion, and you're doing gas exchange here. This is a therapy that's employed when somebody is generally critically ill. This is, in the last decade or so, we've been able to push boundaries with ECMO, and people can be sustained on ECMO for longer periods of time, more safely or with fewer complications. But typically people start to think at about 14 days is really, when you look at the data, that the risk of being on ECMO goes up, and those risks are infection, bleeding, stroke, and so they're fairly significant risks. And this is a picture that I found on Google, where the source of all good things are, and it's actually from CHOP, but the same setup. And so the circuit, this is the ECMO circuit here, and you can see all this red tubing. This is all the tubing that I was talking about, and the patient's here, and so you've got all this tubing here and the heater and oxygenator and this type of stuff. And so this is a pretty intensive therapy. You can't really walk around with this therapy, though some adults, in fact, waiting for lung transplant, you can actually do it. But in general, in children, this is a therapy where you're bed-bound. You're on a ventilator, which is over here. You've got all these other medication supporting things. Typically, you're sedated and paralyzed. So this is not a long-term solution. And I don't know, was it Nicole who was the introductory speaker? So as she said, you don't get to pick if you're waiting for a transplant. You don't really know when that transplanted heart's going to come, and in most areas in this country, at least, it's longer than 2 weeks. Sometimes this is a temporary therapy. If things are going really poorly, you can use it just to buy some time and institute other therapies that may get the heart to a point where you can separate from this machine but not need to go right on to transplant. So it's used in different ways. To talk a little bit about VADs, so ventricular assist devices, and this is a schematic of a pulsatile VAD. This is sort of the first generation of VADs in adults, and the current generation of VADs in children, though hopefully we're moving to some other VADs. And so the concept here is that there are two pumps, and they're pneumatically driven to a console that would be the size of maybe this table or bigger next to the patient, and you're connected to that. And so this is the left heart pump and the right heart pump, and so this would be a BiVAD setup. And you've got outflow from the left ventricle. These arrows, I didn't put these arrows on there, but they're backwards. So there's outflow from the left ventricle into the pump, and then to the ascending aorta here. And then this is from the right atrium. Again, these are backwards. So this would be from the right atrium into the pump, and then to the pulmonary artery. And so these pumps do the work of the left and right ventricle. They don't do any gas exchange or oxygenation. This is in children, most children will get a pump that's termed a Berlin Heart, or X-Core, Berlin X-Core. And so this is a company called Berlin Heart out of Germany, obviously. And so this is a boy on an LVAD. And so you can see the pump here. And so this is the pneumatically driven part from this console that he's sitting on. And then there's a membrane here that separates the blood component here. And so this should be the inflow or from the left ventricle into the pump, and then this should go back. And I'm not showing you the pictures, but they're tunneled. It's tunneled sort of right under through the skin and just above the diaphragm. And so you can ambulate on this. You don't need all that support that I showed you in the other picture. This is where VADs are in adults, and this is where VADs are going in children, hopefully. And so this is, you can see the size of this pump, and this is what it looks like. And this is a slightly different version of a pump. There's not the pulsatility. This is a continuous flow pump where there's a rotor in here that spins and basically draws the blood in here and then pushes it out here. So that stem is in the left ventricle here. It's surgically implanted, and then we get pushed out into the aorta here. There's a drive line here. He's wearing battery packs and a small console that just sort of displays some information about the pump, the speed of the rotor, that type of thing. This is a patient with an LVAD, a heartware LVAD implanted, and you can see that you can't really tell from, I mean, you can tell the person's obviously had surgery, but it's very different than the other setup I showed you. And this is the drive line coming out to the battery pack here. So, so those are, again, the VAD and ECMO are therapies that you would employ with severe heart failure, generally as a bridge to transplant. In adults, the LVADs, because they're, I don't want to say they're easy, but because you can look like this and you can search on the internet and you can see people walking around and climbing mountains and doing things with LVADs, it does allow for an ambulatory lifestyle. There are risks to these machines as well. Clotting is still a risk. The device actually works very well, but you're always got to be tethered to power, so there's not so much device failure as there are complications with bleeding and mostly clotting. But these are bridges to transplantation, typically. So let's talk a little bit about transplantation. And this, I think, was when Shelley had reached out to me and asked if I would come speak. This is what I think she wanted me to talk a bit about. And I'll try to give a very balanced view. In my day job, I'm a heart failure cardiologist and I'm a transplant cardiologist. I see patients who have heart failure. I follow a number of patients who have Barth Syndrome. And I also take care of patients who get and who need and who get transplants. And so I see the spectrum and I see the pluses and minuses on both sides. And I tell families the first time when I sit down with them, our job is, if you need a transplant, we'll do it, but I don't want to push people to transplant prematurely. but I don't want somebody to not do it if they really need it, okay? So it's not a cure. That's also the first thing I tell folks. It's major surgery. You need to be well enough to survive that surgery. And then the circumstances need to be such that it's going to be worthwhile. So somebody who has advanced body disease and their kidneys have failed, and they've had a severe stroke and don't really interact with a good quality of life, that may not be a good transplant candidate. It probably isn't a transplant candidate at most centers. And there's a major commitment to long-term care. So everybody in this room who's affected by Barth's knows very well about long-term care. There are some patients, though, who come to us who have not had any medical history in the first time. They have severe heart failure, and that's a big shock to that patient and to that family. And it's a challenge to go from not needing any medicines and being healthy to being very severely ill and reorienting a bit of your life around, or a good bit of your life around, medical care and appointments and follow-up. And so it requires follow-up at a specialized care center. Fortunately, there's a large number of pediatric heart transplant centers in this country now. I think 20 years ago it was a bit different. And the care is rigorous. It never is zero. There's always an appointment. There's always labs. There's always something. But the care at the start is, at least in our center, you don't even, once you get discharged from the hospital, if you live far away, you're not going home for another month to 2 months. We tell folks 2 to 3 months, and it's hopefully a little sooner. And then you're having biopsies where we look for rejection, and you're having procedures done, and you're coming to clinic a few times a week. So it's fairly intense, but let's say you're 4 or 5 years out, we're doing a biopsy once or twice a year, and we're seeing you in clinic another once or twice a year. So there's labs. I don't want to minimize it, but I want to say that there's the potential for quality of life as well. And then, of course, the long-term need to take medicines. So why is heart transplant not a cure? So there are risks and side effects to immunosuppression. The body is going to reject that organ. It's basically the body's recognition that the heart is foreign, just like if it was an infection, a bacteria, a virus, and it's going to try to destroy that. And so without immune-suppressing medicines, the heart will be destroyed by the body. And unfortunately, with immune suppression medicines, in most patients, long enough time, the heart will be destroyed by the body. And that's what we're working towards not having happened, and that would be a holy grail of transplant. So there's acute rejection, where the heart sort of acutely suddenly is sick and injured by the immune system and doesn't work well. If you over-immune suppress somebody, you're prone to infection. Progressive kidney injury, one of the side effects of the main medication that you take, tacrolimus or cyclosporin, they both have this side effect, is that it injures the kidneys over time. And then also, when you suppress the immune system, one of the possibilities is that you'll develop a cancer. One of the roles of the immune system is to sort of scavenge maybe cancers that are just starting in our body and we'll never know about. And when you hamper that ability, those cancers can become clinically apparent. And then, as I said, limited long-term survival. So the next few slides, I'm just going to show some data from an international transplant registry on a few of these topics, just to give you a flavor of what we're talking about. So for acute rejection here, there's 2 eras, an earlier era represented in green and a more recent era represented in this purple. And what you can see is, if you just look overall, as time has gone on, acute rejection, this is in the first year percentage of patients, and these are children. This is all pediatric transplant data, heart transplant data. Percentage of children experiencing acute rejection in the first year, it's about 15%, whereas it used to be closer to 30%. So it happens. And then you can see the breakdown by age group and by sex. So it certainly occurs. This is a wrong title here. I apologize. This is basically, I'm just showing infection as a cause of death after transplant, and you can see that this is broken down by interval after transplant. So in the first 30 days versus more than 10 years out. And you can see percentage-wise, it's generally around 6%, with this exception of after 30 days to a year. But it also is a real phenomenon and can happen. Fortunately, I don't feel like we see it this often, but it can happen. Cancers or malignancies, in looking at patients who survive 1, 5, and 10 years out, it's not super frequent, but it happens, 2%, 5%, and 10% incidences. And most of these are lymphomas. In adults, it would be more skin cancers and some other things as well, but most are lymphomas. And these are not all fatal, but they're certainly significant complications and require chemotherapy at times and can be a very serious complication as well. This is just a graph showing freedom from kidney dysfunction after transplant, and it's broken down by age at transplant. But essentially what you can see is, somewhere between, the younger patients seem to have fewer problems with kidney dysfunction at 10 years out, but you can see that it certainly happens in somewhere between, let's say, 86 or 87% and 96%. So, maybe 4% to 15% of patients by 10 years are going to have significant kidney issues. Children, this is all pediatric transplant data. And so then the other main issue is this issue with long-term survival. And so these are, this is again from the same data set. This is survival by era after transplant in children. So earliest era is this blue line here, green, red, and then purple is the most recent era. And so what you can see is survival, let's say we call it something, median survival is about 50%. You drop your line here, so median survival for this earliest era was only about 10.5 years, and in the next era, when you get to 50%, it's about 13 years, and not enough time has elapsed for these to get far enough out. And you might say, well, as the era is getting better, these lines are higher up, and that's good, and it is good, but all the change has actually happened here. If you look, right, it's just how far they drop in the first month or 2 months or whatever this little interval is going to be. And so this is the problem, is that the slope of these lines are all the same. And this is what I do when I'm not doing heart failure, is I'm concerned as to why long-term post-transplant survival isn't great. The slope of the lines being the same means that so we're getting a benefit early on. We've learned how to take care of stuff early after transplant, and patients don't die as often early after transplant, but late after transplant, this line remains to be seen, but the slopes look very similar, which says that there's still a steady attrition after transplant that's unchanging. And so this is something we need to change. I'm not going to go too much more into it other than to say it probably is also a form of rejection, chronic rejection, where the arteries of the transplanted heart become thickened, and the heart doesn't get enough blood supply chronically, slowly over time, and maybe doesn't squeeze as well or doesn't relax as well, and can lead to a need for retransplantation. Just in terms of quality of life, I wanted to change topics. So so those are the bad things about transplant. What are the good things about transplant? So here's data again from that same registry, and this shows quality of life data. And so 100% is full. The red is fully active. This is functional status, 100% versus 10% of normal, if you will. And so, and this sort of equates to being fully active, minor restrictions, active but tires more easily. And you can see that for almost the vast majority of patients at 1, 2, and 3 years out from transplant, this is at least 95% or higher, fall into one of these 3 categories, with most falling into this fully active category. So quality of life can be very good. So graphs only show you one thing. Pictures may show you another. I won't say who because I don't have their permission, but one of the 3 nurses in this picture is a heart transplant recipient, and in fact a kidney transplant recipient after that. Actually, she's a double heart transplant recipient and a kidney transplant recipient. And so quality of life can be good. You can work. You can do things. This is another boy that we follow after heart transplantation, and a third boy that we follow who's styling with his car there. So my point is basically to say that if you look at these pictures, you can't tell. These patients go to school, they go to work. I have patients who are nurses. I have somebody who's in business school. So life can be very good, and the quality of life can be very good. So I think the question we want to ask in this group is, so are patients with Barth syndrome transplant candidates? And perhaps Nicole's alluded to her experience that the answer is yes, and I would say the answer is yes. So what I did, just to get a little bit more data, because I didn't find much out there, is there's a group called the Pediatric Heart Transplant Study Group that our center is one of a member. There's 52 centers in the world, most are in North America. And I polled the group informally, just asking about people's experiences with Barth syndrome and transplantation. And this is the data that I was going to summarize for you here. So I heard back from 25 of the 52 centers, so just under 50%. And this was just an email request, so nothing formal. And we may try to formalize this because I think it's actually really interesting data that's not been reported. But so I was able to find at least 24 patients who have received a heart transplant at 19 different centers. And I'm not going to identify any centers. I'm just going to give them labels. And you can see some centers had no experience. Most centers had one. One center had 3, and a few had 2. In terms of by year, if you look at the data by year of transplant, you can see at least there's, it's a little bit more weighted from 2009 onward. What's the age? So the median age is about 1.7 years, ranging from 28 days to 18 years. Now again, these are pediatric centers that I polled, so the upper age is, got cut off at 18 or 19 because they're probably not doing transplants in 25, 27-year-olds. It's not to say they're not done, I just didn't poll the right group. The average age is about 4.5 years. Was the diagnosis of Barth syndrome known before transplant? And in most cases it was. And were any of these patients supported with these support devices that I described to you? And about a third were. And these don't add up to 7 because some patients had both ECMO and VAD, so they're not mutually exclusive groups. So there's a video, I don't know, is it Freddie? Do you mind playing that video now? Is that all right? So there's a video I couldn't get to embed in my talk. I apologize. I just want to play it. This is of a boy that we recently transplanted who has Barth syndrome and who recently had a heart transplant, and he's on a Berlin heart. And if it actually plays smoothly, you'll see him run down the hallway here. Maybe not. You'll see him, yeah. So, so anyways. So not as smooth as I would have liked, but the point is to say that, yes, so the same therapies that we're employing in other patients who don't have Barth syndrome, we can employ in patients who do. Great. So then I also looked at, just did a quick, thank you, Kaplan-Meier curve showing survival after transplant. And again, this is not terribly scientific. I don't have the finest bits of data, but you can see that survival is here's 75%. So let's say this is, I don't know, what is this, 85, I don't know, 90%. I don't actually know what the number is here. And just as a comparison, here's that red line from the curve that I think is accurately represented in terms of these two axes here. And so this is not scientific. I wouldn't compare these statistically necessarily, but it's certainly in the ballpark of what we would expect for all children getting transplanted. Okay, it's not out there. It's not some crazy therapy. So what about infection after transplant? I told you that's a risk factor, and it's a risk in anybody. What about in a patient with Barth syndrome who has neutropenia? There was no report of infection, again, in this informal survey in 68% of patients, 15 of 22 that I was able to get data on. And at least 11 of them had reported neutropenia, again, through the centers, and 10 were on Neupogen that I could gather from the centers. So a couple of comments about infection. So I asked people just also for comments. You never know what you'll get back. And so, I heard one patient with pneumonia at least annually, one person with a sepsis event when they had an IV in place after transplant and had respiratory, this is a baby, had a respiratory infection with bronchiolitis. These things resolved. And so these are, yes, they happen. These happen, this could be any patient in my mind, and not necessarily a patient with Barth syndrome who had a transplant. This patient unfortunately died of an undefined pulmonary process that they suspected to be infectious. A patient with other pneumonias, other viruses. This is a patient with this abdominal wall skin infection or soft tissue infection while neutropenic and not adherent to their Neupogen. So can happen, but none of these struck me as things that were, again, outside of the spectrum of what I would see in patients who don't have Barth syndrome. Some other comments just in general about outcomes or events related to transplant. So this person had severe antibody-mediated rejection and was relisted. This person was doing well and starts nursing school next month, so I thought that that was great. Wasn't my patient, wasn't the one I showed you. This person had rejection and some nasal obstructive issues. This person is described as being active, energetic, normal school, normal growth and development. And these are, again, all patients with, this is the Barth syndrome experience within the PHTS. This person with some late kidney disease, there's some feeding issues and NG tube dependent, but moving to PO, oral feeding. Some issues, this person had a VAD and had an embolic complication where a clot came out of the VAD and went down to the leg and compromised flow to one of the leg arteries and required an amputation. This person's very delayed. Kidney failure early on after transplant, fully recovered. Attending college, has myopathy that continues to limit quality of life. So as I read through these, again, it's a small sample size, but none of these things seemed outside of the experience of what I deal with in other transplant patients who don't have Barth syndrome. And so to me, it says it's a perfectly legitimate therapy if it seems to be appropriate. So the last question then is, when is the right time for a transplant? And this is the question that is going to be unique and individual to every patient's own experience, and this is the reason why you get to know your doctors really well and they get to know you really well, in my mind. When somebody's this sick, obviously it makes it pretty easy to think that a transplant is warranted, though I will say, and have had the experience, that in patients with Barth syndrome, we know that in early infancy they may struggle, but if you can support them through that and get through that, that they actually may do very well. So that's the one caveat I'll add there, but you know, I think you at least have to, when you're this sick, you have to at least list and be thinking about it and then see where things go, because you don't always have the luxury to play time off itself. You kind of just have to play the game. What if somebody comes to clinic with Barth syndrome and they look like that, but their echo, I don't know if this will play, but looks like that. So they look well clinically, their echo doesn't look very good. This is the patient you struggle with some more, and you say, boy, you know, I don't know. And this is why you repeat the echo and you look serially and you look at BNP levels and you look at other things and you get a sense of, you know, what's the trajectory. So what we need are, so last thing is that, you know, so typical indications for transplant is that they have somebody has intractable heart failure with a low likelihood of survival, or they have heart failure with an unacceptable quality of life in their current situation, and that there's no reasonable alternative for the reasons I described. But again, it comes down to we need better predictors of who needs a transplant and who doesn't. And I'll be honest with you, at this point we don't have them, and we have to rely on our experience, our gut, our knowledge of the patient, our sense of the trajectory. You know, what we want though are biomarkers that would be predictive of future events, that you could say now, okay, well this is trending in this way. When we've seen the last 30 patients do this, they've gone on to either be, you know, not survive or need a transplant. That's what we need, and we don't have them. And hopefully, with the scientific sessions that are happening here and the science that was out there, we'll get some of those things, particularly with Barth syndrome. But we need it in pediatric heart failure in general. So I'm happy to, but I don't have the answer ultimately. But I'm happy to entertain questions, comments, and I thank you again for allowing me to participate.
Doctor, what's the view of either you as a heart transplant doctor or just a transplant community about putting a healthy heart in a child that has all the issues associated with Barth syndrome versus other options with other people who have a healthy body but need a heart?
So I think it's a great question to ask. I think hopefully the data, you know, part of the reason I wanted to poll that group's experience and put that data out there, and I think it's important to put that data out there, will be to say that, you know, as I looked over the data again, I thought that the experiences I was seeing was kind of what I would expect and not outside the realm of appropriate. I thought it was very appropriate for a transplant recipient. And so in that sense, I would say for Barth in particular, again, every patient's unique, but if you're just going to put that global label on it, to me that's not we say contraindication. That's not a reason to say no. Now, I mentioned early on, if somebody has a severe neurologic disability and they have very limited interactions, and they have kidney failure already, and maybe their liver doesn't work very well, and to throw on top of it, maybe they've not been really good with taking their medicines, they've had some chronic, that is a less exciting, that makes it less comfortable, to say that, as you said, there's a vital resource. There's only about 350 pediatric heart transplants in this country a year. That's it. That number hasn't changed, and I've been doing this for a while now, and that number's been the same since I was a fellow, and the reason is there's not enough donors. So we do have to be a little bit judicious about how you're going to utilize an organ. They don't just come off a shelf. They are a precious resource, but I think you have to take each case individually. And kind of put the data together. But in general, I would say in a patient with Barth syndrome, I don't, that's the point of having that data, is to say that any case, an N of 1 may be just unique, but as a global condition, there's no reason in my mind, based on what I've seen there, to say that Barth's wouldn't be, Barth's as just a category, oh, Barth's, forget it. No, that's not the case at all. Did that answer your question? Yeah. Great. There's a question over there. Yeah.
Is there a day coming when hearts will come off a shelf 20 years out, where it's either mechanical hearts or hearts can grow from stem cells?
Yeah, I think yes. The answer is yes, but I don't know if it's 10 to 20. So the question was, is there a day coming where hearts will be more routinely available, either they're grown or they are come off a shelf or there's mechanical? So my answer will be yes, but I'll qualify that with it may be 100 years from now. I don't know. There's certainly a lot of people looking at scaffolding technologies where you take a heart, where you sort of grow a heart basically with stem cells in a lab on a collagen scaffold, and that type of stuff is making progress. The machines are getting better, and so that HVAD hardware I showed you, there's a newer, smaller one that's going to be coming out that may be more appropriate for children, and the side effect profile isn't perfect, but adults sometimes are relegated to, we say, destination therapy. They're not a transplant candidate, maybe because they're 83 and they have smoked and whatnot, but they might get a VAD and they might live another 4 or 5 years. So for a kid, that's not a good option, but I think that's where the field is going, and at some point, yes, that will be an option, but I have no idea when. So, thank you so much.
Oh, I've got one more question, Dr. Feingold. You said that LVADs and ECMOs are usually a bridge to transplant, but we know that with our boys as well, that we've got this sort of undulating phenotype. Have there been any cases in the Barth syndrome population where they've actually been able to come off LVADs and not go on to transplantation? So
I think that's a great question, and I'm glad you brought it up. I didn't even think to cover it. There is a field of VADs, people, I don't say a field, but there's certainly thought within the VAD community of how do we decide who is a candidate for a VAD as a bridge to recovery, meaning that the VAD can go in, do the work of the heart, let the heart muscle rest and repair, and then can you take that VAD out safely? And so we're really bad, I would say, as a field of understanding who those patients are. I'm not aware of any patients with Barth syndrome who have had that. That patient that I showed who was on the VAD, that was the discussion that we had with the family initially. And we talked about it, and we said, well, let's get to 8 weeks out on the VAD, see where we are, do some measurements, and we didn't feel like that his heart was showing signs of recovery enough that we had the confidence to take it back out, because it's a major surgery to take it back out. And in fact, once you've taken it back out, you may have burned a bridge. It may be hard, really hard to put it back in, much harder than the first time. Scar tissue, bleeding, complications. And so to me, that's a decision you really have to get right. And I think you're going to, at this point, I'm going to err on the side of leaving it in and doing a transplant, then taking it out, because I think if we have the uncertainty, that is where our responsibility lies, is to go with the strategy that we think is going to buy that patient the most years of longevity. Now, I will tell you, in the months that boy had his VAD, we had another baby, not Barth's, another baby at our hospital, and we did take her VAD out, and she is doing well now, about 2 or 3 months out, off of a VAD, and she came in with a severe dilated cardiomyopathy on ECMO. And so, it may be that we understand that certain conditions are something that you can recuperate with a VAD, and certain conditions aren't. But I think we're at a very nascent stage, and we don't know. We don't have great predictors. Just like I don't have great predictors for exactly who's going to fail and go on to need a transplant, I don't think we have really great predictors right now as to who could be a good VAD explant candidate.
I'm just wondering, what's the longest time someone's gone with a heart transplant that you're aware of?
So a single so generally you would think that somebody who's a newborn or an infant under a year is likely to get the greatest longevity out of that heart, perhaps because their immune system is immature, and though there's never tolerance where the immune system fully accepts that organ and won't try to reject it, at least not that we know of, it just may be more tolerant of the organ. So I believe, I want to say I've heard of folks like getting low 20s to mid 20s. I don't know the exact number though. I doubt it would be much higher than upper 20 years with a single heart. Thank you.